Hello everyone. So in today's video we are going to learn how do we have to study Toronto notes. Okay, so for Toronto notes you have to do is you have to start with MCC objectives. Once you get onto this MCCQE1 objective website, you have to get into MCC objective and then medical expert. Once you click on the medical expert, you will get all these objectives that you have to cover for QE1 exam. Okay, so let's say we get into section P, and in section P I am going to discuss the subjective psychosis today. Okay, so how are you going to incorporate it into your preparation? So you see, the psychosis is one of the objective on MCC website. You have to quickly have an idea like what do they want you to know. Psychosis is a severe and disabling psychiatric symptoms present in several disorders, the most common of which is schizophrenia. It can be associated with severe psychosocial dysfunction and can be life threatening. So, what are the causes? Psychotic disorders, schizophrenia, schizoaffective disorder, psychotic disorders due to medical conditions like seizure disorders, central nervous system tumors, substance induced psychotic disorders like corticosteroids and cocaine. So, these are the three major causes of psychosis in a human body. One is psychotic disorders, the other one is due to medical conditions like seizures and central nervous system tumors. Third one is substance induced like cocaine and steroid. So these are the three major ones that you have to remember. Given a patient to psychosis, a candidate will diagnose the cause. So you need to know the cause, the severity, and the complications. Will initiate the appropriate management plan. So you need to know the complications, management plan, severity, and complications. In acute psychosis, particular attention should be paid to differentiating from primary psychotic disorder from delirium and from psychotic secondary to medical conditions and substance induced. So you should be able to differentiate between the three conditions that are mentioned above: psychotic disorders due to medical conditions, due to psychiatric conditions, and due to substance induced. So you need to know the differences. Like for instance, if a patient is having a family history of schizophrenia, this is most likely from schizophrenia due to psychiatric disorder running in the family. Let's say if a patient has seizures or epilepsy, and now he is coming into ER with psychosis, that is due to seizure disorder. And if a patient has a history of drug abuse, then that could be from cocaine intoxication. So that's how you need to differentiate, and then there would be some presenting symptoms as well that would help you differentiate in the cases. Going ahead, enabling objectives are critical clinical findings, including mental status examination, attention to risk factors for harm or self harm. So, one thing in psychosis is you need to see if the patient is suicidal or not. Collateral history, if available, physical examination with particular attention to findings suggesting an underlying or coexisting medical conditions, substance use, appropriate lab investigations, including neuroimaging. Now, this is the effective management plan. You have to ensure patient safety certification. Like these are the certifications they're talking about, is the one for involuntary or voluntary admissions. Ensuring ongoing assessment of capacity, we need to check for capacity to see. Let's say if a patient is suicidal, then he doesn't have capacity to consent for the treatment. Then who's the SDM? So that's how it works, right? Pharmacotherapy, both acute and maintenance. So for acute conditions, if a patient currently is in psychosis, what medications are you going to give? And once the patient is being discharged, what medications are you going to give at that time, right? So that's what you need to know. Attending to the patient's psychosocial needs, community and family resources, housing. So family resources very, very important for psychiatric conditions like schizophrenia, because there is one kind of therapy, that is family therapy, that is incorporated into the treatment plan for schizophrenic patients. Treating underlying disorders and comorbidities, counseling and supporting patient caregiver family about psychosis, in counseling and educating the family as well, referring the patient for specialized care, referring to psychiatric care. So this is the objective, right? Now you know that there are three different types of causes for psychosis, and they want you to know the presentation. How would you differentiate if a patient is presenting in ER? And then they want you to know the severity, the complications, and also last but not the least is the management plan. They want you to know the management plan, and there are two different types of management plan. One is in the ER, and the other one is the routine management. So if this is an ER condition, you'll definitely start this topic from emergency medicine from Toronto Notes. So I have this Toronto Notes open in front of me. Let's say emergency medicine. So I'm sure you see ER 56 shows that there's psychiatric emergency. So let's open that up. and I'll directly jump to the psychiatric emergency. Once you get into psychiatric emergency, this is going to be a very important part of MCC objective. Why? Because this is one of the aspect of psychosis, the emergency aspect, and then there is a routine aspect, right? So in emergency aspect, what you need to know is approach to common psychiatric presentation before seeing patients. Ensure your own safety. Have security police available if necessary. Also, you see they have written psychiatry PS2. That means in psychiatry you have to also cover this part from PS2 section. Okay. Now, what are the key functions of emergency psychiatric assessment? Is the patient medically stable? Rule out medical cause. Is psychiatric consult needed? Are there safety issues? Suicidal or self harm? Is patient certifiable? Must demonstrate risk, present or past tense, and apparent mental illness, future tense. Okay, so you need to take their history. You need to check their if they have the the capacity to make decisions, if they're suicidal or self harming themselves, and if they need a psychiatric assessment. So these are the key functioning psychiatric assessment. Also, you need to check if the patient is medically stable or not. Right. So history, safety is first. Your safety, your patient safety. Okay. So your safety is first, and then your patient safety. You have to assess suicidality, suicidal ideation, passive or active. Passive means the patient was thinking about, that he should not be alive. But active is like he has a plan and he wants to kill himself right away. He has a gun in hand, so that's an active suicidal ideation. Intent, plan, lethal means, past attempts, protective factors. So you need to know what are the certain things that you need to have in the suicidal history. We will cover this in the suicidal, and I have also covered it in the suicidal psychiatric video that I've made. So you'll see that. Assess homicidal ideation, access to weapons, intent, victim, and history of violence. Driving in children is very important, because if there is a children along with a psychiatric patient, then you need to report it to CS for child protection. Command hallucinations, identify current stresses and coping strategies. Mood symptoms, patient is depressive or manic. Anxiety, panic attacks, generalized anxiety, phobias, OCDs, post traumatic stress disorder. Psychotic symptoms. Now, what are the psychotic symptoms that you're going to look for? Delusions, hallucination, disorganized speech, disorganized or catatonic behaviors. Negative symptoms, affective flattening, alogia, and evolution. Okay, alogia is patient does not speak, he's speechless. Evolution is like he would not really interact with anyone and he would just be himself. Substance use history, most recent use, amount, previous withdrawal reaction, past psychiatric history like medications, adherence with medications, admissions, and medical history. Obtain collateral if available. If there's a family member available, make sure you get history from them as well. On examination, you will focus on vitals. You'll check if he's vitally stable, blood pressure, heart rate, everything is okay. Now you'll move on to neurological examination. You'll check for any cranial nerve problem, like you'll check for oculomotor nerve, you'll check for optic nerve, sign for head trauma, any bleeding or discharge coming from nose or ears, signs of drug toxicity. What are the signs of drug toxicity? You're going to look into his eyes for meiosis or meiosis or dilation of the pupil. You'll check for tremors, signs of metabolic disorders, which could contribute or causing psychiatric presentation. What are the metabolic disorders that could present with psychiatric presentation? It could be low sugars. Patient may present with delirium or dizziness. And also mental status examination. You will check for general appearance, behavior, cooperation, speech, mood, affect, thought, content, form, and perceptual disturbances, cognition, MMSC if indicated, and judgments. Investigations, that was one of the QE1 objectives. So you need to know what investigations are you going to do. So it depends with age. Establish psychiatric diagnosis versus first presentation. History and physical suggestive of organic causes. So if the patient is coming in for the first time, he's a young patient presenting in ER with psychosis. Let's see, his friends let's assume the friends are bringing one of the 25-year-old male to ER with psychosis, hallucinations, delusions. What blood work are you going to do? You will do blood glucose levels, because you're going to see if the patient is hypoglycemic. You're going to check urine and serum toxicology. Very, very important for a young patient presenting in ER. Urine and serum toxicology screen. Pregnancy test in a young female. Electrolytes, TSH, AST, ALT, bilirubin, serum creatinine, blood urea nitrogen, osmolality, blood levels of psychiatric medications. So if the patient has a known case of psychiatric condition, let's say schizophrenia, has some kind of bipolar disorder, you're gonna check the blood levels for their specific psychiatric medication. CT head if suspect neurological causes, LP if indicated, NMDA receptor encephalitis. Acute psychosis is differential diagnosis, primary psychotic disorder, schizophrenia, secondary due to medical conditions, could be delirium, drug induced. So, this is the same classification we read in MCC Objectives. So, you see how Toronto Notes is collaborating with MCC Objectives, and that's how they want you to know, right? So they want you to know the primary diagnosis, let's say primary psychotic conditions like schizophrenia, schizophreniform, secondary conditions like delirium due to low sugars, let's say, abnormal electrolytes, or any drugs like steroids or cocaine or anticholinergics. Infections, CNS, metabolic conditions like hypoglycemia, hepatic or renal or thyroid problem, structural problems. So they want you here, they would want you to do an imaging, CT head to see for hemorrhage or neoplasias. Autoimmune like anti-NMDA receptor encephalitis. How would you manage the patient in ER? Violence prevention. Number one is violence prevention. Patient with psychosis would be violent, remain calm, empathic, reassuring. Ensure safety of staff and patient and have extra staff and security on hand. So first thing is your security, your staff security, and then the patient security. And then a patient demonstrating escalating agitations or overt violent behavior may require physical restraining or chemical restraining. So the patient is violent, you have given medication and he's still violent, you need to have physical restraining or chemical restraining. Treat agitation. Whenever possible, offer medication to patient as opposed to administering with force. Help calm and engage patient. What are you going to give? You're going to give benzodiazepine, lorazepam 2 mg per oral intramuscular sublingual. Very important exam question. Which medication are you going to give? Lorazepam 2 mg per oral intramuscular or sublingual. Or you may also give antipsychotic medications like olanzapine 5 to 10 mg per oral or intramuscular, haloperidol 5 mg per oral or intramuscular. So you need to know the dosage of these three medications. Lorazepam is 2 mg, olanzapine is 5 to 10 mg, and haloperidol is 5 mg. Treat underlying medical condition, psychiatric or crisis intervention team consult. These are the important terms to remember for your exam. Crisis intervention team consult. So first thing is first, violence protection, violence prevention treatment is lorazepam 2 mg or antipsychotic like olanzapine or haloperidol 5 mg. Then treating the underlying medical condition and referring to the psychiatric consult. So this is the psychotic part of acute psychosis. Now we'll just quickly cover the suicidal part as well. Attempts are more common in female for suicide, but so complete suicide is more common in men. Second leading cause of death in young patients. So suicide is more common in young patients, and there are specific kind of people who perform or who do suicides. These are marginalized communities, particularly indigenous people or LGBTQ population. Why? Because of denial, because of not the families are not recognizing them. They deny their identity, so that's how people are depressed and they perform suicide. So that's one of the things, that indigenous people have their own past traumatic disorders. Then marginalized communities, they are neglected, so they perform suicides. What is the management? Ensure patient safety, close observation, remove potentially dangerous objects. Number one is patient safety, close observation, remove potentially dangerous object from the person and the room. Assess thoughts, ideation, means, action, preparatory practice, practice attempts, previous attempts, protective factors. Admit if there is an evidence of active intent or organized plan. Assess to lethal means, psychiatric disorders, intoxications. Suicidal ideation may resolve within few days of abstinence. Patient may require certification Form 1 and 42 if unwilling to stay voluntarily. So if the patient is in the office, is not willing to get admitted to the hospital, so you have to unwillingly admit the patient, and that is the Form 1 and 42. Form 1 is to notify the patient that you're going to admit him, and Form 42 is to notify the hospital and the facility that the patient will be admitted and he is having this condition. Do not start long-term medication in emergency. Obviously, you're gonna start with lorazepam or olanzapine or haloperidol. That's what we just did, right? Psychiatric consult is the most important thing in the entire plan of suicide or psychosis, right? Patient safety, acute treatment, Giving Form 1 and 42 and psychiatric consults are important factors in this. Who are the patients on high risk for suicide? Sad person is best mnemonic that you can remember. As for sex, that is male, age more than 45. Depression, previous attempts of suicide. Ethanol use, rational thinking loss, suicide in the family. If the patient has a history of suicide in the family, he will be at risk of suicide again. Organized plan, no spouse, no support system, serious illness. So these are the risk factors for patient who can commit suicide, right? So this is something that you have done, let's say, okay. And on the right side there's psychiatric review of systems, mood, organic, anxiety, psychosis, and safety. Okay, so now move on to the PS2 part, the psychiatric part of let's say psychosis. So in once you enter this chapter, psychiatry, let's see. So in psychiatry, you can see it starts with psychiatric assessment, history and mental examination, assessment plan, and suicide. So let's move forward and see what they want us to do. So this is PS2. This is the exact same paper that was mentioned on emergency medicine portion. So you have to complete the history part from here. And on the history part, you need to know what you're going to take history from the patient, from the family, what are the important aspect of the history, okay. So once you cover this part, you will move on to the mental assessment as well. And till suicide, you have to cover this assessment and plan, and till suicide you have to complete this objectives. Once you've completed till suicide, now the next part of the psychiatry is psychotic disorder. Psychotic disorder does come under psychosis objective, but schizophreniform, all these disorders have separate objective as well. So if you want to cover it separately, you can do it separately, but I would suggest if you can continue and do it along with psychosis, that would be wonderful, because now here you will learn the chronic management of schizophrenia. There you learn the acute management, here they will tell you about the chronic management, what medications you're going to prescribe and so on, right? So that's how you have to cover. Let's say, okay, one more important thing here I have to tell you, that you see this key the sign on the just besides the blue bar. So make sure everything that has a key in Toronto notes, you have to cover it, because this is the MCC objectives. Okay, so if you go onto the first few pages of Toronto notes, you will see the abbreviation or whatever, explanation for this key is that this is a part of MCC objective. Suicide is one of the objective, no doubt. Psychotic disorder is objective. So anything that is objective, they would put key, but that's not necessary. But where you see the key, make sure you cover it, do not leave it, okay. Now once you've done psychosis, now what I suggest you is, on Telegram you can find the offline version of UWorld. So I would suggest you to do offline UWorld uh, from here, from Telegram first. You don't have to buy it if you don't have Toronto notes, that's okay. UWorld, that's okay, but make sure you get offline version of UWorld and incorporate UWorld into your preparation. So this is psychiatric behavior and substance abuse UWorld. It is around 1200 pages. That should be around 2 to 3 blocks or maybe more than that. So let's do one question and then we will conclude the video. So how would you read the question? You will read a question in a way: which of the following is the most likely cause of this patient's cognitive impairment? So this is an 85-year-old man comes to the office accompanied by his daughter due to memory problems. The patient is a retired accountant who lives alone and has been managing his finances and housework until a month ago. He says, I have had to ask my daughter to shop for me and help around the house. I kept forgetting to turn off the stove and could have easily burned down the house. The patient has been more tired than usual and sleeps through his favorite television shows. He previously maintained a rose garden but now feels it's not worth the effort. The patient's daughter says he was due for his medical refills last week but still has a few pills left because he sometimes forget to take them. Medical history includes hypothyroidism, hypertension, hypercholesterolemia, TIA 2 years ago. Temperature is 99, heart blood pressure is 141/87, pulse is 76, respiratory rate 14. Weight is up to 4 kgs from the last month, and TSH is 4. His score is 21 on 13 on MCA. Mocha score is 21. It has reduced with deficit in delayed recall and attention. What does it seems to you? Is an 85-year-old with memory problem, short-term memory loss, low Mocha, thyroid is okay, patient has gained some weight, so but there's no psychosis. This is mostly dementia. So this probably should be Alzheimer's or major depressive disorder. Um, let's see. I would say this could be, but patient has also gained weight. So this could be depression. You see, this is depression. Why? If they're giving you any findings, make sure you take that, because Alzheimer does have dementia problem. But if there's any physical findings they're telling you, make sure you do not ignore that. Mocha is less than 21. He might have Alzheimer's too, but depression is more common. Now you need to know is how would you differentiate depression from Alzheimer's. So if there was any answer that you thought was the answer, make sure you read it. Let's say I was thinking about Alzheimer's, so let's read this one. This patient, 1 month, his course of functionally impairing cognitive deficit associated with other depressive symptom is better explained by depression related cognitive impairment. Alzheimer disease follows an insidious course developing over several months to years. So Alzheimer's would not develop in 1 month, right? So this is something that I need to make a concept for, that Alzheimer will be developing in few months rather than just 1 month. So the diagnosis was depression. Elderly depressed patient can have a significant cognitive impairment that may be mistaken for dementia syndrome. However, unlike most dementias, depressive related cognitive impairment is reversible with treatment of underlying depression. So this was depression because it develops insidiously over a course of 1 month. So major depression is reversible. Mild, moderate cognitive impairment, features of depression, more interest, energy, episodic, weeks to month. Whereas normal aging is slight decrease in fluid intelligence, normal functioning in all daily activities. So that's how you will complete your objectives. Make sure you at least complete one block, or maybe, so in depression you will give psychotherapy and antidepressive medication, right? So that's how you're going to complete the questions. And yeah, I hope you like today's video. If you have any questions, you can comment down below and I'll try to address all those questions and answers. So good luck to you with your preparations, and let me know if there's anything specific topic or anything you want me to review. Thank you so much for watching. Make sure you subscribe to my channel.